The reason that we perform aortoiliac ultrasounds is usually to follow up aneurysmal disease or to identify it. We're looking for atherosclerotic disease and stenoses. Sometimes physiologic testing will indicate that there's inflow aortoiliac disease and we want to define that more precisely, or to follow up after open or endovascular repair. Other indications would be claudication that interferes with the patient's occupation or lifestyle, usually one that would indicate that there's inflow disease such as the hip or the buttock area. Abdominal bruit or decreased femoral pulses may prompt an exam of this sort, or postoperative findings after angioplasty or stent to look at that and how that is faring. It may be emboli in the ischemic digits that prompt the exam, or again follow up to any kind of revascularization. So let's begin with aortic aneurysm and just quickly talk about that. The incidence of aortic aneurysm in the general adult population is about 60 per 1,000, and it is the 13th leading cause of death in the United States. 15,000 patients die annually from ruptured aneurysms, and there are more than 50,000 aneurysm repairs, both surgical and endovascular, annually. This occurs more often in men than women. It is mostly infrarenal, but can be suprarenal or, of course, thoracic. It is usually defined as a focal dilatation of greater than or equal to 3 centimeters. Some literature says 3.5 in AP diameter. In general, if they are under 4 centimeters, most centers will observe those. Once they reach about 5 centimeters, they are a candidate for elective repair, and once they get larger than 5 centimeters, usually patients that are candidates are offered surgical or endovascular repair. Of course, if there's rupture, then they would require immediate attention and repair. Aneurysms are usually in 2 forms, either fusiform or saccular. Fusiform aneurysms are fairly easy to turn and get into an orthogonal or perpendicular plane and measure. Saccular are a little more difficult, and sometimes it requires the plane of either the sagittal or the transverse to accurately measure those. Here's normal aorta. You can see the walls are nice. There's no ectasia associated with this, as opposed to this image in which there's aortic ectasia as well as the dilation in the distal aorta. The most common sites for aneurysms are aorta femoral, popliteal, and those are bilateral about 50% of the time, and iliacs. And the most common complication associated with the aneurysm is distal embolization and thrombus. And again, these can be fusiform or saccular, but most of them are fusiform. Let's look at an iliac aneurysm case. We often see iliac aneurysms associated with aortic aneurysms. This is a patient who had an infrarenal abdominal aortic aneurysm on CT scan with left common iliac artery involvement, and had an ultrasound to confirm the hypogastric artery prior to embolization, and this was to be done prior to an intervention. So here's the iliac aneurysm. You can see that a large portion of it is thrombosed, and you can see the thrombus in it. It's a very large aneurysm, over 3.5 centimeters, and in the sagittal view you can see it extends all the way to the level of the bifurcation, so that is why they want to address this patent hypogastric artery. And we need to define the size, document the flow through that, so that we know post-hypogastric coiling what will be going on with that. So here's the documentation of the spectral waveform of the hypogastric in preparation for that coiling. In addition to aneurysms, we're looking for dissection disease. Here you can see the intimal wall of this aortic dissection. Here's another example in transverse, and then that same artery in the longitudinal view. Here's an interesting aortic dissection. You can see that this is curved up in this direction. This patient had recently undergone a renal intervention in which a catheter was approached in this direction. There's a large mound of plaque here, and when the catheter hit that plaque, it was forced downward and lifted the intima. And this was during certain portions of the cardiac cycle, waving and opening and closing. It was not causing enough of a hemodynamic impact to address it at that time. We're going to also look for aortic stenosis. We're going to look for iliac stenosis, aortic occlusion or iliac occlusions. Here you can see an occlusion at the level of the terminal aorta with collaterals coming off. We are confirming with spectral Doppler that that was actually occluded, and as well as with color and B mode. Now, iliacs, once they've been chronically occluded, are very difficult to see. They begin to blend in with the surrounding tissue, and so you really need to use your vein as your landmark to help you see it and find it, and then you can put your spectral Doppler in where you see the sort of atretic artery and confirm that there's no flow when you suspect occlusion. So now that we've talked about the types of disease that we're going to be looking for, let's talk about how we do that and what the role of the vascular laboratory would be. Well, we're going to determine whether or not there's disease present, how severe is it, precisely where is it located, and we may be able to assist in determining therapeutic options for those patients with stenoses or disease. The pre-intervention, we're going to talk pre-intervention, post-intervention, and then we're going to talk about aortic endografts. The pre-intervention duplex complements the physical assessment done by the physician on the patient, as well as any physiologic testing or angiograms done prior to the duplex ultrasound. This is more specific localization of the disease than the physiologic test, and we can determine it primarily, is that disease focal or diffuse? Where is the exact location of disease? How severe is it in terms of percent stenosis? What's the length of the stenosis? If there's going to be an endovascular intervention to this, that might help them determine the size of the balloon or the catheters that they're going to use. And if there's adequate visualization, you can measure the external diameter and residual lumen, and that may assist in determining what appropriate endovascular device to be used to address this problem. What do you need? You need high-resolution duplex ultrasound. This is not a study that's probably best done with one of the smaller laptop-type systems because you need really strong, good, robust color and spectral Doppler deep in the abdomen. You're going to use lower frequency transducers and perhaps use several of the transducers, maybe a curved and a linear, and you may have to go to a phased array or an annular array based on the patient's body habitus. We usually keep these patients in PO, don't normally do a bowel prep for them. So the technique would involve a thorough examination of the entire aorta and iliac segments in both transverse and sagittal planes. However, the abdominal aorta and the iliacs are usually best imaged in their long axis, but transverse will help you identify the course of those vessels. Lower frequency pulse Doppler transducers, high resolution, always less than 60 degrees in the center stream of the vessel to document the velocities. Color flow is very helpful. Iliacs are often very tortuous and deep, and of course we always have to deal with overlying bowel and gas. You may need to turn the patient, you may need to use differing approaches to be able to access each segment of the iliac arteries, and we found that the lateral decubitus position is really a helpful approach. This picture is a 3D reconstruction of a 1 millimeter CT, and you can see here that this is quite an angulated aorta, and you can also see how tortuous these iliac arteries are. And even though a standard axial CT would drop the plane this direction, we're able to put a plane in these CT scans in a orthogonal or perpendicular approach, and that's what we do with ultrasound to be able to accurately measure the residual diameter here. You need to recognize that there are some limitations and challenges to this examination, obviously obesity, poor cooperation, and it is sometimes very difficult due to this tortuosity to obtain adequate angles under 60 degrees. So it requires some due diligence to do that. We're going to use imaging color flow and Doppler and sample a spectral Doppler throughout, usually proximal, mid, and distal in the common iliac, proximal, mid, and distal in the external iliac, the origin of the internal, and then the femoral bifurcation. You want to be parallel to the wall, and you want to make sure that the Doppler cursor is parallel to the wall and as you go through each segment. And as I said, that is going to take some manipulation to be able to do that adequately at under 60 degrees in tortuous vessels. So we'll look at the aorta, proximal, mid, and distal, and then the iliacs, including the hypogastric or internal iliacs, and using the image, B-mode image color flow and Doppler, we're going to assess this thoroughly. Spectral waveforms are collected throughout the aorta and iliac segments, and then I normally would collect the runoff vessels of common femoral SFA and PFA origins as well. Special attention is then paid to color flow patterns where you can see if there's elevated velocities that suggest a stenosis. This is what we want to see. This is a nice, normal, triphasic, high-resistant iliac waveform with a nice spectral window and return to forward flow after the reverse flow component. You can see that this is parallel to flow, nicely parallel and an appropriate angle.